So my name's Bhavika. I'm a rheumatology registrar working in Leeds. I'm going to talk through an interesting case of a leaking valve in a young girl with lupus and work a bit backwards towards my learning outcomes, which come at the end of the presentation and are posed as questions to the audience, really. So this young girl is 26 years old, but was referred to us at the age of 18. She has a pre-existing cardiology background of congenital heart disease. So she was born with an atrial septal defect, a doming pulmonary valve, and a mild mitral valve prolapse. She had surgical closure for her ASD at the age of 10 and remained under the congenital heart disease team with 2 yearly surveillance echoes. They were satisfied with her post-operative function. She had no ongoing cardiology symptoms and was managing well. She was referred to us at the age of 18 with a polyarthritis, fatigue, myalgias, mouth ulcers. And as you can see, her serology, if it's maybe a bit small, but she's got homogeneous positive ANA, a high titer double-stranded DNA of over 100, and a positive chromatin antibody. So putting that together with her symptoms, her new cytopenias, a low C4, and we diagnosed her with SLE and commenced her on hydroxychloroquine and some steroids. Things started going downhill over the subsequent weeks, and she ended up in hospital with a presumed pneumonia, the productive cough, fever, consolidation on her chest X-ray. She got treatment for her infection with IV antibiotics, but also some lingering symptoms of a lupus flare. So she was started on a weaning course of steroids, and mycophenolate was added as a second DNOD. At this point, her serology was repeated, and her double-stranded DNA was pretty high, 300. Her C4 was quite suppressed, and we repeated her APS screen, which showed a persistently positive lupus anticoagulant on more than 2 occasions, but her other antiphospholipid antibodies were negative. Over the following months, as she came to clinic, she kept describing symptoms of pre-syncope, dizziness, exercise intolerance, struggling to even make it up the stairs with progressive shortness of breath, bearing in mind she's only 19 at this point. And I'm sure you've seen the report there, but I'm going to show you the echo images, which are thankfully working. And thank you to our cardiology colleague, Chin, who's helped put these onto the screen. But even to my untrained eye, you can see a lot of flow in the wrong direction. So there's regurgitant flow clearly from her left ventricle going into the left atrium, described as torrential. So very severe prolapse of her mitral valve posterior leaflets, showing essentially a new severe mitral regurgitation, a dilated left atrium, and also mild to moderate tricuspid regurgitation. Just to keep in mind, she had been having 2 yearly echoes, and her last echo had been quite satisfactory. So this was very much a new finding after the diagnosis of SLE, and probably triggered by her recent infection and recent SLE flare. This was her chest X-ray, so huge heart, particularly large left atrium, blunted costophrenic angles, signs of overload. So after an urgent cardiology MDT with rheumatology presence, it was deemed that she needs urgent surgery. The discussion was around surgical valve repair versus replacement. She's young. Replacement would mean a mechanical valve at this age, and therefore putting her through lifelong anticoagulation. So repair was felt the more ideal option at this point, but with a provisional plan for a mechanical valve if there was a lot of residual regurgitation. So she underwent a mitral valve repair, tricuspid valve repair, and closure of the atrial appendage. Intraoperatively, the findings were consistent with a very dilated mitral valve annulus, lots of regurgitant flow, but interestingly, no vegetations were seen, and they weren't seen on both transthoracic echo or transesophageal echo. Intraoperatively, the cardiothoracic surgeons commented that there wasn't significant inflammation that they would expect to see with a non-bacterial thrombotic endocarditis. But as she had a repair rather than replacement, we had no surgical specimens to send to the lab for histopathology. She received low molecular weight heparin perioperatively, but instead of prophylactic dose, we went for treatment dose, which was initially planned as a short-term perioperative regime and kept being increased and prolonged, and I'll show you why. So from a rheumatology perspective, her treatment was escalated to rituximab, which she really didn't get on with, had a severe rash, cytopenias, and a primary non-response. She continued to have further flares of her SLE, and over the next years developed GI involvement with serositis, mesenteric edema, which responded well to steroids and cyclophosphamide, and she was ultimately switched to B-cell depletion therapy with belimumab, and methotrexate's been added in for her joints. Probably even worse from a cardiology perspective, she's ended up in and out of hospital with ECGs looking like this. Interestingly, the top left ECG is from her Apple Watch, which are very good nowadays. But the other ones are her in-hospital ECGs. So she came into hospital with SVTs and heart rates ranging up to 230. Vagal maneuvers, the usual ALS algorithms were unsuccessful, and she's had a number of unsuccessful ablations as well, and has ultimately gone on to have a pacemaker inserted with an AV node ablation and a percutaneous clip repair for her tricuspid regurg. So in this context, she now has lifelong anticoagulation with warfarin. And her latest echoes, as of a few months ago, show severe tricuspid regurg despite the repair and ongoing moderate mitral regurg despite the repair. So for me, this brings me on to what my questions were really from this case, but also what my learning outcomes were. So one, what do we think caused this young girl's valve failure? She has SLE. She has a positive lupus anticoagulant, which is persistently positive. She has pre-existing congenital heart disease. She is immunosuppressed. And two, how do we manage her, in particular from a thrombotic risk perspective? So again, she's got a lupus anticoagulant, but no obstetric or clinical history of VTE. She is at high risk of thromboembolism perioperatively, but also in the long run. She's also at risk of bleeding. And which drug would be most appropriate? So talking about valve failure in SLE, so the original sort of prospective Doppler echo studies quote rates of about 18% with valvular involvement in SLE. And since then, obviously, our cardiology imaging techniques have improved a lot. And now there's very varying reports. We know that valve thickening in SLE is actually very common and usually mild and asymptomatic, but the rates quoted for severe or symptomatic valve disease necessitating repair or intervention are somewhere around 12%. What causes this? Probably a multifactorial. So chronic inflammation, immune complex deposition, complement activation, and endothelial activation as a result of active SLE in the chronic setting. Could this be an SLE valvulitis in a similar way that we think of pericarditis, so inflammation? And in that case, could it be reversed with immunosuppression alone? Or is this microthrombi deposition, and in combination with the inflammatory element, are we forming non-bacterial or non-infective vegetations, which look like that intraoperatively? So just to mention the numbers that have been quoted in the literature, probably the biggest study with the longest follow-up was a Spanish study looking at 61 patients with SLE and 40 matched controls with Doppler echoes over a period of 14 years. And they quoted a very variable rate, but from 40 to 70% of patients had valvular abnormalities in the lupus group, and only 12% developed severe regurgitation. In all of the papers that I've had a look at, there is a clear correlation with positive antiphospholipid antibodies, and in particular with lupus anticoagulant and a high titer IgG antiocardilipin. A meta-analysis of 23 studies, so about 1,600 patients, which is the largest that I could find, found a threefold increased risk of valvular disease in patients with SLE and positive antiphospholipid antibodies, which would fit with our patient. So she's hypercoagulable, probably prone to thrombus formation on the valve, contributing to valve thickening, but we didn't see any vegetations intraoperatively or on her imaging. This is just to highlight the more recent EULA ACR classification criteria for APS, which has moved away from that historic laboratory clinical obstetric sort of definitions, and does actually include a weighted scoring for cardiac abnormalities, including 2 points for valve thickening and 4 points for valve vegetations. Which takes me on to how do we manage her thrombotic risk? So we had an MDT with the cardiologist and the hematologist, and no one had a clear answer. In the initial setting, we agreed that she's very high risk of a thromboembolism perioperatively, and instead of giving her prophylactic dose, low molecular weight heparin, we went with treatment dose tinzaparin, presuming that there's a probably thrombotic element to her valve failure. We weren't sure how long we were going to continue this, and initially we said about 6 months, and then she went on to develop severe biatrial dilatation, lots of atrial tachyarrhythmias, and therefore obviously had an indication for longer term treatment. And she's ultimately been switched from low molecular weight heparin to warfarin, which runs all of the other troubles with monitoring of INR, particularly with repeated steroid doses and all of her other medications. There are a lot more studies looking at valve replacement rather than valve repair, but there is a systematic review showing cases from over a 10-year period highlighting that repair is feasible. But I don't know what's going to happen in the long run and whether she's going to ultimately need a valve replacement looking at her most recent echoes. So that brings me to the end of my case, but what I'd really like to open up to the audience is if other people have seen cases of severe valve disease in the context of lupus, and if anyone has other suggestions for my two big questions, which I asked here. Thank you very much.
Thanks very much for the excellent talk. We've just got a question online. So we have Dr. Badal-Powell.
Yeah, thank you. A very interesting case. I was just wondering, at the surgery, was there any cardiac tissue available for histopathology and or culture?
No, so she had a repair rather than a replacement, so no tissue was taken or sent off for histopathology, which obviously would have been very helpful from a diagnostic perspective.
Okay,
Yes.
Thanks.
Valve looked normal and the mitral annulus was very dilated. Was this considered to be primary mitral valve disease or secondary mitral valve disease, secondary to dilatation of the annulus? Or do you know which one they were falling at, if you know what I mean? I wonder if it was like disease. I wonder if it was disease.
I think if you speak into the microphone,
Oh,
because
sorry.
they can't hear you.
I was just saying, just because they were saying that the annulus of the mitral valve was so much bigger and the valve itself seemed normal, I wondered if this was seen as more of a disease of the apparatus as opposed to disease of the leaflets themselves.
So there was clear prolapse of, I think, P2 and P3, so all the posterior mitral valve leaflets on all of the echo imaging prior to the surgery as well. So I think of the valve itself as well as the apparatus.
Okay.
Yeah, it was. I mean, it's interesting because the valve really didn't look very thickened at all. So I don't know if other people have seen this before, where you get SLE valvulitis with, because as the intraoperative, with the sort of theory suggested, you know, the mechanism of inflammation didn't appear to be there visually. So I don't know whether anyone's seen that before, if that's common or not.
Does anyone want to comment from the room or online? Whilst you're thinking about it, put your hands up online if you want to join the discussion. I will say that when we see in vasculitis, particularly ankylosing valvulitis, it is something that destroys valve function. It can be very difficult, tricky to diagnose, and I've never seen it repaired. I've only ever seen that replaced. I think Maya's sort of nodding along as well, so she's in agreement, others in the room. So I suspect that if that was the cause, that might be the issue here. And it can be very tricky to diagnose that. It's a shame, very, very difficult when you can't have tissue to make these decisions. And it's nice to try to spare the valve if you can. And I know there's data on that. But if the valvulitis is the major problem, I think it just repairs long-term the valve actual function. Any comments online, or anyone want to come in on that? Maya?
I suppose we need an expert in the room, and also to that point, in a young person, one would want a definitive procedure. They're still left with moderate MR. So arguably, in terms of prognostic long-term outcome and LV and all the rest of it, that situation hasn't necessarily changed. So was there a discussion normally about where valve repair is considered, or replacement in that context, even in normal general population?
So I think the plan was replacement if a significant residual MR post-operatively, which actually there wasn't on the echo soon post-operatively, and this is a few years, the latest one is a few years down the line, so clearly things have developed over time, but she did have pre-existing quite severe biatrial dilatation at this point, so it does look like she's definitely heading towards a replacement.
Probably the best thing for her. Does anyone have any comments online or in the room? Any questions? Oh, any genetic genetic causes that you're aware of?
So she's quite interesting. I skipped over a few things for the sake of time, but she did have the pre-existing congenital heart disease and a few features that raised the question around a dysmorphic genetic cause initially, but these had all been explored by the time she came to us. So she's quite small in terms of height and growth. She'd had a history of recurrent chest infections in childhood as well, and had a sort of delayed period, delayed secondary sexual characteristics. So different genetic syndromes like de George's syndrome, which can cause cardiac involvement, had all been discussed and explored already, and nothing had been found.
Ben?
The question to Jason, do you think preoperatively PET would have been helpful in this patient? If given, I think the echo looks pretty, as was commented on, pretty bland, and you wouldn't think as necessarily it's an inflammatory process there. But as
Yeah, I mean, it's
Taryn said, we may miss that. And can PET help here, or could have helped?
good thought, and certainly something to consider. But I guess the use of PET in sort of native valve endocarditis is less good than prosthetic valve. So could be useful, but not necessarily with visualizing the native valves.
But we are using cardiac gated PET more and more for endocarditis and Liebman-Sachs endocarditis, and it's very good in that context, isn't it? Is that right?
So yeah, so this is what I'm not aware in Liebman-Sachs endocarditis specifically, but in normal endocarditis, yes, we're using it more, but the guidance is mainly around prosthetic valve as opposed to native valve. But sure, yeah, I mean, it would be something to consider in this case.
We can pick it up here. It's good. It's always we find it a significant challenge to get the patient that's an inpatient a cardiac gated PET. I don't know if anyone else is experiencing this. We had one patient eating porridge on their way down to it. It was extraordinary. So I think it represents some challenges of education, and in rheumatology, because we are not used to requesting the extended fast. I think that is something that we can upskill from a rheumatologist, because I think there's a lot of learning for cardiologists on this course, but some basic thing for rheumatologists is the preparation of a patient for a cardiac gated PET who need a prolonged, protracted carbohydrate fast.
Would you find the cardiac gated PET of value even if she's been on long-term steroids for her SLE at that point?
Yeah, that's a very good question. So if the pathology was infection, then you might find that it would set up. If it's inflammation, no, you're right, you might find it suppressed, and that also is a continual challenge with the FDG tracer. What happens in dotatate with steroids? Do we know?
Well, in vasculitis patients treated with steroids, it goes down, but the time course of that.
We don't know yet.